So thanks so much for having me. Some amazing presentation and definitely a lot of things to consider. Um, we, I do want to applaud the work that this group does. ERC has funded two of my projects, and we have really done some interesting, I would assume, groundbreaking work, more foundational work. So this is just part of the presentation. I'll be talking about uh, artificial intelligence, machine learning in order to predict sort of acuity, particularly in lower back pain, and how it can be translated into other musculoskeletal conditions. First, I want to acknowledge the ERC for providing funding for the project. Actually, I have a previous project that actually translated into this project, so I'm really in debt for things that you guys do. Lower back pain has been my life, and sort of, I think there's so many people who suffers from lower back pain. I've very closely examined this issue, particularly from the patient perspective, and also from the employee perspective, which I see on a regular basis. And so it's a very ubiquitous common problem. The problem is that we have not been really able to really define lower back pain individually, and we lump it up into a thing called lower back pain. Most of Americans suffer from lower back pain. It's very closely associated with the degenerative joint disease. Lots of diseases, especially if you can look up on the right, there's a degenerative joint disease, scoliosis, spondylolisthesis. There's a lot of different conditions that translate into lower back pain. And the problem is there's a significant challenges with the anatomy, mechanical issues, referred pain. So lower back pain is considered a lot more complex issue than what we know. So as like any other case, as a physician, I always like to see a case, and this is a real life case. Names have been changed. Sally, who's been a 43-year-old technician, OR technician, recently fell in the OR and ended up having lower back pain. The floor was recently mopped and it was more slippery. As we deal with COVID situations, we are extra cautious and taking lots of nuance in terms of cleaning the area as quickly as possible. She suffered from degenerative joint disease, which you can see, but she also had a disc herniation, which is protrusion of the disc from the vertebra into the spine, and that causes pinching of the, if you can see, the pinching of the nerve. The disc basically presses on it and causes pinching of the nerve and causes referred pain down into the leg. It's a very common condition. Most people deal with it. There's a lot of things that we do. Sometimes we do non-surgical intervention, and sometimes surgical intervention is needed. Unfortunately, she ended up having a chronic pain associated with it, and ended up having a fusion surgery done, which has its own problems, and suffers from chronic pain now. So it's starting with acute low back pain, now ended up with a chronic low back pain. So when Sally came to primary care doctor early on, and we have a lot of sites across the campus, from Bronx all the way to Staten Island, and we have a lot of physicians who treat lower back pain. She ended up with one of the physicians and being seen for her lower back pain condition. The problem is primary care docs usually see the individuals for pain, but does not really understand the way we can refer these patients back to work, and essentially use return to work as a option to treat these acute cases and bring them back and reduce disability. On the other hand, if you are an experienced occupational medicine physician, you ended up using your judgment, your guidelines, and help those individuals come back to work early, which reduces disability, long-term pain, chronic opioid use, all of the above. So the problem is most people end up having a significant amount of lower back pain from acute and becomes chronic, contributes to low quality of life, additional complications. It's a pretty expensive problem to have. With healthcare, dollars goes into treating lower back pain. But we have good evidence that if you bring people back to work early and reduce the time that they are on disability, it improves outcomes overall. So the first part of the work that we did early on was to build a tool for primary care docs to really make recommendations for patients suffering from lower back pain for return to work. And so we recruited primary care docs and randomized them into two groups, interventional group and control group. The interventional group was given the tool in electronic health record, and they were advised how to address acute low back pain and bring these patients back to work, and that can be used as a tool for improving their outcomes. The problem was that even though the interventional group did end up using the tool more, the control group, which was not given the tool, basically did not have any other recommendation. So in majority of cases, we saw that people don't use return to work guidelines as effectively as it can be done. And one of the reasons I was told is, Dr. Nabeel, you don't understand what I go through in practice, and it's very hard for us to recommend something that we don't have a good understanding. Which led us to a different solution, which I'll describe in a second. Interventional group was statistically significant in terms of using the tool. So it was, if you use it, they usually adopt it. Problem is the frequency, the way we see lower back pain in practice is very erratic and very different. If you have an urgent care provider or you have a primary care practice that's primarily an urgent care practice, you end up seeing more acute low back pain compared to a practice which sees long-term patients where you can see acute on chronic or chronic low back pain. And the problem is the lower back pain comes in different shapes and sizes. So this is just about 40 different ICD-10 codes that we use to describe lower back pain. It's also a logistical nightmare to understand what kind of pain you started with and where you ended up. And the second thing that we realized right off the bat is in coding, which is ICD-10 codes on the right-hand side, you cannot differentiate if the pain was acute or pain was chronic. In our example early on, if we deal with the acute pain, acute lower back pain, we end up improving the outcomes, bringing the person back to work early, and really decrease the morbidity for the disease. But in our coding system, ICD-10 coding system, we don't have that option to understand if it's acute pain or a chronic pain, and most of the conditions are coded similarly. So that bring us to a point where we thought that why can't we train machine to be somewhat think like physicians? They can differentiate, they can make lots of things. So this is an example of system teaching some of the Stanford researchers how to do a ballet dance. So learning from a professional ballerina, they can actually do the dance themselves. So we looked at healthcare in general. Most of the healthcare is based on heuristic decision-making, which is what we do all the time. We're comfortable with something and we end up doing this all the time. Some part of our decision-making is rule-based, which is what we have learned from our experience, and then there are certain rules that we adopt and then help our patients. in that way. The problem with machine learning decision making is it's very minimal. People don't use it as often and skeptic about it. Just to give you a quick understanding, sorry. So there's a lot of different types of machine learning. This is the way a computer see a bus or train and identify it as a bus or truck or a dog or a cat. This is a visual learning for the computer systems. And then we also have a completely new domain, which actually looks at your speech and try to decipher what you're saying. That's how Watson and others have done Jeopardy, and very commonly used now in AI systems. So people think that Google's and Facebook and others have really done an amazing job in developing an artificial intelligence. This is a Google API, which is a system that actually deciphers what you're saying. In this, on the left-hand side, this particular paragraph has been deciphered by Google, and it says what the paragraph is saying. But if you look at the health evaluation, this is an example of a note written by a physician, which says 24-year-old female with lower back pain referred for physical therapy and follow-ups in 2 weeks. And deciphering that information from a machine is very, very tough or difficult. So putting sort of electronic health record notes into Google's system, it does not yield the results that we want to see. So Google essentially, even though it's very sophisticated and I can learn from you, it cannot decipher what physicians are saying. So our goal was to really create a novel approach and build systems that allows us to make a distinction. ICD-10 codes did not solve the problem. Thus, we ended up building a comprehensive electronic artificial intelligence that actually parse the electronic health records, pull up the notes, and decipher the information for us. So we have a significant success with it. It was able to decipher acute versus chronic low back pain. This is just an example of the notes that we pulled. We're able to differentiate how, is it acute low back pain or chronic low back pain? And then also we can differentiate it by diagnosis, related conditions, medicines, and recommendations, a note the physician is writing. I can scale it up from 10 notes to 10,000 notes to 1 million notes, and can figure out who's treated for acute low back pain. The experiment showed a very promising results. And we think that we can replicate that model in other musculoskeletal conditions. There's no manual supervision needed to build this, and machine learns on its own to decipher notes, and which is very, very important if you are connecting with a practice who wants to understand their practice looks like for acute lower back pain, and we can help optimize the care for those patients. Thank you so much for the time. Happy to answer any questions.
Thank you, Ismail. I don't see any questions in the chat box. Anybody? Karen, please. Karen's question, what was the issue with using ICD-10 codes?
So as I mentioned in the talk, that ICD-10 codes does not differentiate between acuity of a condition. Doesn't allow us to look at how acute the pain was, or is it a chronic pain? And over again, we stumble onto that issue. Even though if we labeled a progress notes or physician visit with ICD-10 codes, it actually misclassified or did not classify it accurately. So ICD-10 codes is not recommended, at least from our work, to decipher if it's acute pain or acute on chronic pain or chronic pain. Excuse me.
Michael's question, what was the source of the AI coding?
I'm trying to understand the question. So we.
Michael, would you like to
Go ahead.
speak up?
Sure.
Please remember to unmute.
Did you have to hire a coder to do this, or was this open source or proprietary coding, or what?
Yeah, so all the work we do is open source. I do coding as well. So it was a work done myself as well as another co-collaborators who have very high expertise in natural language processing and artificial intelligence. Yeah.
That's pretty impressive. Interesting presentation.
Thanks. Thank you.
Okay. There are more questions. We will take one more and then forward others to Ismail. Joanne, would you like to speak up? Please remember to unmute.
Sure. Having worked for orthopedic spine surgeons, it was really interesting to hear you talk about the distinction between doctors who, people in your specialty who give return to work recommendations and then other physicians. So I just wanted to ask if, sports medicine, physical medicine, orthopedic spine, or, physical therapists, other allied health professions, if you find that they do provide those that you're speaking of.
So the initial work was done primarily on primary care docs. My second part that we are funded by ERC, we're looking at all other specialties to see if that translates well. But primary care doctors, the adoption of using return to work as an option to treat is dismal. It's not really high. But other physicians, orthopedics or sports medicine, tend to have some better recommendations.
Okay.
Okay. Thank you. Thank you, Ismail, for